This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parts, physical therapist and your host. And today I interview Kristi Maguire to discuss mechanically unresponsive radicular syndrome. Kristi has been a physical therapist since 1997, and she holds a diploma in mechanical diagnosis and therapy. In 2005, she was appointed to teaching faculty for the McKenzie Institute. Kristi dives into a comprehensive literature review to help us better understand this challenging group. In our discussion, you're going to learn about what mechanically unresponsive radicular syndrome, MUR, is, centralization and its relation to the type of disc lesion, probability of spontaneous regression for a herniated disc, how to manage patients with MURs, and effectiveness of epidural steroid injections followed by MDT, and much more. So if you find this information valuable, I encourage you to subscribe to our channel, click on the notification bell to stay updated, give us a thumbs up, and share this episode with other clinicians you think might benefit from this conversation. Thank you for tuning in, and I hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Hi, Kristi. Welcome to PT Pro Talk. How are you today?
I'm good. Thank you, Mariana.
I'm happy to have you here, and I want to get started just asking you to talk a little bit about yourself and your background for the ones that don't know you.
Yeah, so I grew up in Ohio, born and raised. I ended up going through the PT program or deciding that I wanted to be a physical therapist because I was in gymnastics till 18, and one of my gymnastics coaches was in school for PT, and it was my senior year, and I'm trying to figure out what on earth I want to do with my life. I did have an interest in science, exercise, health. So when she told me about physical therapy, I thought, well, that might be a good fit for me. So I volunteered, got my volunteer hours, and I realized that I really did enjoy it. So I ended up going to Bowling Green State University in Ohio, and then the PT school was in the Medical College of Ohio. So I graduated in 1997, and me and my husband met there. We went and moved south to North Carolina, and from there I was in acute care at first, and then outpatient, and then in outpatient I really thought I was going to go down the track of vestibular rehab, and I did a little bit of that. And then my manager needed somebody to take an MDT course. So I volunteered and I didn't know what I was really going to get. I wasn't all that interested, but I was a new grad. So I was sort of interested in learning anything. So I took that course, and really after that first class, I really realized what I was missing in outpatient care. So that really sparked my interest to get certified. And then I felt the need that other clinicians needed to know this. And I wish I would have known it, in school if I could have had that opportunity. So I decided I was going to get my diploma and hopefully teach for the Institute. That was my goal in life as a new grad. So that's what I did. And here I am. And then in 2012, I moved to South Carolina, Greenville, South Carolina, and took a job with IMC, which is Integrated Musculoskeletal Care of South Carolina, and I work at the Michelin Tire Company, and I've been there ever since.
Awesome. So you reached your goal. You are a faculty with the Institute. So
yeah, and not
too that one.
Yeah, not too long ago, I'm like, okay, now where do I go from here? So I'm still thinking about that. So I haven't haven't wrote those goals down yet.
That's awesome.
I'm just cruising right now.
Yeah. And I just imagine how many patients and what a great experience do you have working with IMC.
It has been a fabulous experience. Yep. Very, very neat to see a closed group of patients, because we only see the patients that work there and their families. So I really get to know them individually. I see them for other issues that they might have, and I've seen some, all of their family, so including their kids. So it's really actually been very nice to establish relationships and really build them. And build trust, which is good.
Yes, awesome. Well, so let's jump to our topic today. So, Kristi, what is mechanically unresponsive radicular syndrome? Are they non-centralizers?
Oh, yes. Okay. So an interesting classification for our MDT world. The definition is radicular presentation consistent with a currently unresponsive nerve root compromise. So the characteristics would be a radicular pattern, varying degrees of neurosigns and symptoms. And here's that other question that you just asked. Symptoms do not remain better as a result of repeated movements, positions, or loading strategies. So they are non-centralizers. They don't centralize.
Okay. And so we are talking about centralization. So for the ones that don't know MDT, do you want to just briefly say what is centralization before I ask you the next question?
Sure. So centralization is a phenomenon that we see in the clinic as a result of postures, repeated end range movements, or sustained positions, what we call loading strategies, and what we'll see in a response to a direction where there is a reduction in pain, abolition of pain from a most distal aspect of the symptom that moves proximal. So that's our centralization process. It has to remain better. So as a result of the movement, it actually remains better. And oftentimes we'll see mechanical baselines actually improve as well. They tend to go together.
So, and is it possible that centralization response could be related to the type of the disc lesion? Like we are talking about extrusion, protrusion, and all of that.
Yeah, so there has been some research on this. Of course, there could always be more, and it was more research. I feel like back in the late 90s, the early 2000s, there was a little bit more research back in that time period. But I've got a couple articles for you that might help us answer that question. So one article is in the European Spine Journal in 2011 by Albert and his colleagues. It was called Centralization in Patients with Sciatica: Are Pain Responses to Repeated Movement and Positioning Associated with Outcomes or Types of Disc Lesions? Okay, so when I think of types of disc lesions, I think of bulges, I think of protrusions, I think of ruptures, extrusions, sequestrations. Does that make sense?
Yeah.
So this is a prospective longitudinal cohort study of 176 patients having radicular pain below the knee. And confirmed disc pathology on MRI. So they did an MDT assessment, and based on their symptom response, they classified them in 5 groups. The first group was abolition centralization. The second group was reduction centralization. The third was unstable centralization. The fourth was peripheralization, and the fifth just had no effect. So they were in the no effect group. But what's interesting with this article is 84.8% experienced centralization of some sort. So they were in the centralizing groups, and only 7.3% were peripheralization in the peripheralization group, and 7.9% were in the no effect group. Now, when they looked at outcomes, it's kind of interesting when they took the outcomes were at 3 months and 12 months. So it really doesn't tell us how quickly the centralization group got better or personalization group. So we can't really base any judgment on that. But what's interesting is based on the RMDQ, the Roland Morris, the reduction was a 9.5% or 9.5 point reduction at 3 months and 12-point reduction at 12 months, where the personalization group actually had similar improvement. So I think we need to look at that and knowing that we're talking about MUR, I think that's a big deal because now we're looking at 3 months and 12 months. Do these people actually get better? I think we can draw some judgment on that. And then what they found, though, when they're looking at the actual type of disc problem, is they reported that centralization commonly occurred in those with a ruptured disc, but no association between pain responses in the type of disc lesion. Okay?
Very interesting. Yeah.
Yeah. So then if we look at this was a systematic review by May and Aina in manual therapy in 2012. And this was 62 studies that were included in the review. And this is interesting because we've got, as a whole, looking at these 62 studies, directional preference was found to be greater in the acute population. And they averaged it out to be about 74%. But then they found that as that tissue was going through healing, got to subacute, got to chronic, that actual ability to centralize got less. So by the time they got to chronic, it averaged more like 42%. So I find that compelling that, think about all the people we get from referral sources that has been 6 months. They've been living with it for a while. Here, now I'll send you to PT when it's like, man, if we could just get them earlier, they could potentially do a lot better.
Big difference.
Yeah. So when we're looking at your question with the disc lesion, so now I'm going to go into more like what are the diagnostic implications of some of these studies. Some of these studies do link centralization to discogenic problems and non-centralizers to non-discogenic problems. And that's in the Donaldson study, 1997, Young and colleagues in 2003, and Laslett in 2005 and 2006. And a study by Bogduk and Lord in 1997 was looking at sensitivity and specificity. And what they found was sensitivity of 92% and specificity of 52%. So not all that great there. And then Laslett was sensitivity and specificity of 40% versus 94%. So it's a little all over the place there, but anyway, that's what they're finding. And then Laslett in 2006 found centralization not associated at all with positive responses to zygoapophyseal joint blocks, but was associated with discogenic pain. So some interesting studies there. And then one more, if we look at Donaldson in 1997 in more detail, it demonstrated a significant association between positive discography and the occurrence of centralization or peripheralization. So with the centralization, it was significantly associated with an intact annulus, where peripheralization was not. And when there was no symptom change on the MDT assessment, it was highly unlikely to be associated with discography. It was highly unlikely to be associated with a positive discography. Okay. Studies comparing MRI or CT findings to pain response. Centralization commonly occurred in patients with extrusions and sequestration. So when you look at MRI, you think sequestrations, extrusions, there's no way they're going to centralize. But in fact, they could. So Broats published in 2003, Rapala in 2006, and Broats again in 2008. So that's those studies. So big picture, I would say the answer there is what appears to be some relationship to the intervertebral joint, but to what type still remains unclear. So that was the review, systematic review, and that was their overall statement. And I think that helps us with answering that question.
Yeah, so let's see if I got it. It was just a lot of information. You came prepared with all those papers. So it looks like they are more likely to centralize if they have some disc lesion. Is that right?
Potentially, but what we also find is, I have some general comments about that, because we do know that directional preference can be found when imaging does not implicate discal tissue. So we need to keep that in mind. And we do also see the phenomenon of directional preference in the extremities where the disc is not present. So that's interesting. Maybe we could speculate with the lumbar spine that it's just the disc tissue tends to be a common pain generator. And maybe that's why, hard to say. Patients with sciatica who centralized at baseline had significant improvement in pain and disability, both short and long term, and were significantly less likely to undergo surgery in the following year when compared to non-centralization group. That's just a general comment on, what we were just discussing. And then imaging will not determine if a patient will have a directional preference or centralization, or not only an MDT assessment utilizing repeated end range only the MDT assessment utilizing repeated end range movement, posture, and positions is capable of determining if this phenomenon is going to exist in the patient.
Yeah. So we can say that the MRI cannot predict the outcome with MDT, right? Because it doesn't mean that if they have something in the image, they're going to respond or not respond to MDT.
Right. So I think the important message is that all patients deserve that assessment, not just picking and choosing or cherry picking who should go ahead and go and get that MD assessment, who should not, based on a picture.
Yeah.
Excluding, obviously the red flags, but yeah.
Yeah. What I think was interesting that you mentioned about the sequestration extrusion, that they centralize as well, because you would think that it would be much harder. They don't have any connection. They don't have the mechanism intact. So you would think that would be harder. I think that's very interesting.
Yeah, it is very interesting. Then you have to think about, well, with the MRIs, how reliable are they in determining that? Like maybe it shows a sequestration or extrusion, but if they went to surgery, would it really be there? So how reliable and dependable can you be with those pictures? So,
and another thing that I thought that was interesting that you mentioned about the first study, that 84% were centralizers, right? That's a big number.
It is a big number and a big deal, Yeah. It would have been nice to know sort of what the outcomes were in the short term, like at 2 weeks, 4 weeks, and 6 weeks, and not waiting to 3 months. But we don't have that information. We could probably speculate on what probably happens to those people, because we see centralization and it's usually a predictor of good outcomes, in a short period of time.
Yeah.
But, yeah.
And we know that we have the reabsorption of the herniate disc. And do you think that's common to have the regression, reabsorption with the natural history?
There is quite a few articles that, I was sort of surprised how many articles are out there on reabsorption of the herniated nucleus pulposus or whatever. I have a few studies. Can we go through those?
Yes, please.
Okay. So one was in the Journal of Spinal Disorders Technology in 2005. So this is by Masu, the natural history of patients with lumbar disc herniation observed by MRI for a minimum of 7 years. So this is a small group of patients. So it's just 21 patients with lumbar disc herniation treated non-surgically, were followed for 7 years. They looked at the clinical outcomes over those 7 years. They did a repeat MRI at 2 years and 7 years. And the MRI space occupying ratio in degeneration was then assessed at those time periods. And what they found was the degree of space occupation significantly decreased at 2 years and 7 years. But what they found with degeneration is that it progressed in degeneration at 2 years and 7 years. So the clinical outcome did not depend on the size of the herniation or the degree of degeneration. So interesting facts on that.
Yeah, because so they were not necessarily getting worse because of the degeneration.
Right. So, you think about that. And so many people, look at their image and they think, oh, this is bad. I've got so much arthritis in there, right? I'm in horrible pain. I'm never going to get better. All that psychosocial that goes with, knowing what that picture looks like. And, every decade is not going to look better, but that doesn't mean you're going to have worse and worse pain, So,
yeah.
There's a couple more that I have that could help us with this question. One is in spine in 2006. This is by Alcio and his colleagues, or him or her colleagues, determinants of spontaneous resorption in intervertebral disc herniations. And what they found is migrating and extruding type of herniations have a higher tendency to decrease in size in follow-up studies. And that takes us down to a similar finding by Chu and others in clinical rehabilitation in 2015 found similar effects for those people. So this is called the probability of spontaneous regression of lumbar herniated disc. And this is a systematic review, which is kind of nice. And what they found, patients treated conservatively and had repeat MRIs of the lumbar spine. They did exclude the lumbar spine surgeries, infections, tumors, spondylolisthesis, and stenosis. So they did exclude those people. But they found spontaneous regression in 96% for sequestration. And then on 70% in disc extrusion. So if people can rate out the pain, there's a good chance that they're going to get better. 41% for disc protrusion and 13% for disc bulges. So it does, correlate with what Alcio reported in 2006. Very similar. So it seems like if it breaches the annulus, it has an easier chance to regress or reabsorb.
Yeah. So the natural history is going to help those that can tolerate the beginning of the pain. So they can see if they're going to have some regression. And it's interesting that, do you know why? Would you have like a hypothesis of why like sequestration, extrusion they have higher percentages of regression than like a bulging disc?
Yeah. Well, let me answer that in just a second, because this other study sort of had some theories on that at the end. So this was a study by Gupta. And this was, does size matter? An analysis of the effect of lumbar disc herniation size on the success, or disc herniation size on the success of non-operative treatment. So this was 368 patients of lumbar spine herniations between 2015 and 2016. MRI confirmed their herniation. They had 6 weeks of non-operative care. So that's going to be NSAIDs, steroid injections, PT, and pain meds. And then they exclude the cardioquinine, progressive neuro, bony fragment, spurs, and end plate material. But they measured the length and width of the herniation into the canal and the canal area and disc area. And 32 of these patients required surgery within 2 years. But the percent of spinal canal occupied by the herniated disc does not predict which patients will fail non-operative care. So it sort of answers those questions we've been asking before. And non-operative treatment and require surgery within 2 years of the MRI. So the size did not predict he was going to go to surgery, and he wasn't. So that's good to know. And their theories on the theories on how it progresses and how it, the size kind of regresses over time. They said potentially the posterior longitudinal ligament tension improves. There's potentially reabsorption by macrophage phagocytosis, the white blood cells, going into the area, maybe recognizing that material is foreign to that area of the spinal segment, and it starts to, disintegrate it. It's potentially maybe some lymphatic drainage and immunological reaction. So I'd say that phagocytosis would be an immunological reaction, and maybe dehydration over time. So there's not really some good solid facts out there, but there's some good theories out there.
It makes sense. That would be easier to just get rid of those pieces that are there disconnected and identify as, strange bodies, strange things occupying space.
Yeah, that's right.
So one of the things that you said, let me see if I got it right, is that the size of the herniation does not predict if they're going to have surgery or not. So it's not necessarily related to the space that they occupy. Is that right?
That's right. That's exactly right.
Interesting.
Mm-hmm. Yeah, and that, connect that to MDT assessment, who's going to centralize and who's not. You can't really look at the picture and determine, whether that patient can get better over time, whether that patient's going to centralize or not centralize until you put them through the assessment or give them time to try to recover.
My next question, I think that most PTs are probably now wanting to know, how do you manage these patients that are mechanically unresponsive radicular syndrome?
Well, just as a general comment, I see a lot of spinal patients in my clinic. And because Michelin is self-insured, we don't have as much of that limited number of visits. You only get 4, then you have to ask for more. We don't have that, we don't have that to deal with, which is really actually very nice, because if somebody can get better, oftentimes with these people, it's going to take time. And it doesn't mean that they have to have a huge number of visits, but you do need to help them through the process, because it's hard for these patients to get through this. Based on your experience and based on research and how the body heals, that there's a good chance they're going to recover without surgery. They don't know that, So let me go through some management of patients with classification of MUR. So in general, depending on where you are in MDT and your experience and your training, for some, it might be just that first visit. It's pretty obvious, but for others, it might take 2 or 3 visits to confirm. And then depending on your experience with it, maybe it takes up to 5 visits, so it can take some time to confirm. So then after that, you have to make a decision. Do you keep them in the clinic or do you refer them out? Right? So that's another challenge for us clinicians to make those decisions. So emergency referral out is going to be your cord compressions, your cauda equina. Those are going to be more, let's get them to a specialist. And sometimes to the emergency room. I've had my experience with that. And then worsening, identifying the neurological symptoms from day one and identifying whether or not that neurosymptom is getting worse. So if it's a deteriorating neurosymptom and it's gradually getting worse, then they need to be referred. So that might not be your first day. It might be a couple visits in, you're realizing that their condition is worsening and it's not turning around and it's not stabilizing. So those people would need to get referred on. So, and then we've got to deal with the challenges that come with such a painful experience for the patient. So I look at this as managing the psychosocial aspect of this particular condition. Think about the fear the patient might have. They might be in fear that they're never going to feel better again. They might be like, oh my gosh, do I have to live like this? They may want to jump into surgery right away because pain will drive you to do crazy things, Then think about, they might be depressed, frustrated, they're worrying, they're anxious, they can't do their tasks at home, things are building up, that's very stressful. Then their belief system might be just malaligned, they're not thinking, properly through this, and jumping into things that they don't want, shouldn't probably jump into right away, where they might want to just go right into surgery. It's like, no, let's just stop. Let's step back. And how do we deal with the psychosocial? Well, that's going to be a lot of education. Calming fears comes to, the fear with this is more, they don't know. So the more they can know about it, maybe that fear can start to kind of subside. So if we can give them an expectation on time frame, so think about what we just talked about, like the 2 months of just dealing with the worst part of it. And if they can wait it out, it typically does get better. Most people don't have to go to surgery. Look at all the studies we've looked at, right? So the few do, but most don't. So then we got to go through the healing process. Well, how is this going to heal? Where are you in the healing process? Explain to them, are they in the inflammatory state, acute phase, repair phase 1 versus repair phase 2 or 3, depending on how their symptoms respond and stuff like that to movement and where they are in the time frame. And the management, what our management is intended to accomplish, and that is to facilitate recovery, right? And let them know, what we're going to do is try to help this tissue get through healing. So, and then of course you have just a few that might be towards the end of repair, be centrally sensitized. And I'll just save that for last because it's just an interesting group of people. But we could share the research with them. What is the research on natural history? Most people get better in spontaneous recovery, spontaneous regeneration or regression of the symptoms. The body trying to heal, share that with them. And then, that eases people's fear and anxiety. Yeah, there's hope.
Some hope.
Hope, right? There's no reason not to. And then, of course,
hope that I'm going to get better.
I think that's super important. That is just super important, and it buys you time to try to help them, right?
Yeah.
And then also just letting them know what their other options are. If what we're doing to help it facilitate recovery is, if we need a little help, we can ask the provider for medications. There's medications that can help us out. We got the NSAIDs, we got the oral dose packs. We've got injections, and we can talk about the MDT and the injections and how effective they are. So we'll go back to that in just a second. And then we have surgery, right? So if you put the options on the table, a lot of people really don't want to go to surgery. There's a few that really are all into the surgery, but most people, especially with the spine, don't want to go there. Yeah. So that buys you time too. And that helps them know, what are the other options? Are there any better options? Well, surgery doesn't sound like a better option unless they really need it,
Yeah. Yeah.
So
setting their expectations of what they can expect on all the process, all the treatment.
Right. So then I was going to go into staging the condition and the characteristics we might see. Do you want to go back and talk about the Hans study on the injections?
Yeah, however you want to do it. If you want to talk about it, I was going to ask you about those, how do you see them helping those cases that there is a lot of studies, right? Combining the injections followed by MDT. So that was going to be another thing I was going to ask you. I don't know if that's what you're talking about.
Yeah. I thought maybe we could talk about that now because then that will take us into our treatment options. So Hans, like you were talking about, Hans van Helver and his colleagues in 2014 in pain medicine, they looked at transforaminal epidural steroid injections followed by MDT to prevent surgery for lumbar disc herniations. And this is really interesting. You got 69 patients. They were determined as non-centralizers, and they were referred and consented to having a herniated disc surgery. So they were prepared for surgery. They had already failed conservative care with medication, analgesics, and general physical therapy. So keeping that in mind. These patients had extremity pain with or without axial pain. MRIs confirmed disc herniation and 2 or more positive neurological signs. So that's this group of patients. So then they saw these 69 patients, and they took them through an MDT assessment. And they did an MDT assessment twice to confirm that they were non-centralizers. So in effect, these were MURs. They didn't give them any treatment before the injections. And the patients were given up to 4 injections, and that was just based on their symptom response to the previous injections and how much pain they were still in. But once they received their last injection, then 10 to 14 days later, they received another MDT assessment. Okay, so here's what they found. 11 patients were completely resolved. So no pain, no movement loss, everything normal. Right? So when you think back, okay, those people are probably primarily inflammatory conditions. You're not a lot of mechanical issues going on there. And then you've got 32 that were now centralizers. So they turned into, they were now reclassified into the derangement group. And then significantly less pain. And they went on, of course, and improved and didn't need surgery. And then you had 11 that were still in the non-centralizing group. So they were still non-centralizers, but they still had significantly less pain and still went on to do fairly well and didn't have surgery. And then you had 15 that were non-centralizing with ongoing high levels of pain and disability, and they all continued to surgery. So you had 69 patients were about ready to go to surgery, and ultimately only 15 needed to go.
Yeah, that's huge.
That is a huge difference. And then they've also done similar style of research on cervical spine. I'm not so sure if it's published. I haven't seen it yet, but they had 41 participants for cervical spine MUR, and 12 resolved after the injections. 19 became derangements. They were centralizers. 5 remained non-centralizers, and 5 went to surgery. And with the thoracic spine, from what I understand, they're seeing similar effects or similar responses.
So there are similar responses, neck and cervical, thoracic to lumbar.
Yeah, that's very, very interesting. And it helps us too, right, with the MURs. It's like, what are the other options if they aren't gradually getting better?
Yeah. And I wanted to ask you on those that became centralizers, because you said that the ones that just got better with the injections are probably more inflammatory. So you calm down the inflammation, they get better. The symptoms resolve by themselves. How about the centralizer? So do you feel like there is less inflammation so they can do the movements better and then respond because you can test them and move them in a different way that they can tolerate? Or like, what would be the explanation?
Well, if you have a mechanical problem that has all the characteristics of derangement, but they don't have a directional preference, everything's aggravating it, then maybe what's keeping them from being able to have a directional preference is the inflammation. And knowing inflammation, there's never going to be a directional preference in that stage of a condition. So that's likely get rid of that inflammation, and now the mechanical response is capable of change, or the mechanical problem is capable of change. And then you can also look at MURs who don't go through any surgery or any injections. Some of the MURs, as they're getting better, turn into derangements over time. So maybe as tissue recovers and tissue is not so inflamed, now they turn into having a directional preference because you can truly change the actual mechanical problem. So,
and when do you decide that would be a good time to try injection? Like you exclude the red flags, they are stable, but they're just not responding and getting maybe getting even worse or just with unbearable pain.
yeah.
Then you decide to try the injections. How is that rationale behind to get to that point that you refer them to injection?
Okay. So let's talk about managing the bio part of the biopsychosocial. Let's talk about managing the MUR and the actual problem. So what I like to do, it helps me understand kind of where they are in the healing, is really stage the condition. Are they in acute or subacute repair process or time frame? Are they in repair phase 1, which is inflammatory, or repair phase 2, which is going into that second phase of healing, coming out of inflammation? So very highly sensitive groups of people in this time frame. So the characteristics, you would find constant symptoms, constant maybe going towards intermittent, but highly irritable with all activities, positions, and movements. The movement loss is there. It's your typical obstruction, as we would call an MDT. As you see that movement loss pattern, that's typically your posterior lateral compartment is not moving right. And maybe you see that with extension, side glide, extension with hips off center, kind of getting in that posterior lateral compartment. And you really see moving into that is really painful. And it goes down the leg. Every once in a while, you have somebody very, very sensitive to movement, but not a lot of movement loss. Okay, that might be that chemical group, that the ones that Hans talks about gets completely well with just the injections and there's no movement loss there. Maybe it was just really a predominantly chemical problem without much of a mechanical problem. And then basically during this time frame, inflammation is dominating the condition. So inflammation dominant. So then what are the goals? The goals are to reduce inflammation. So we'll get to answering your question, I think, through this. Well, how do we do that? We're going to set up the tissue with an environment for healing and recovery. All right. So how do we do that? So we could look at that and say, well, in our assessment of all those different directions you tested to come up with the fact that they're MUR, right? So a lot of testing had to take place. Well, if you pay really close attention during these tests, you may have found a position that eased the symptoms. All right. You wouldn't call it a directional preference. It didn't remain better, but while they're in that position, symptom intensity got less. All right. So that could be an option. That is a good position for that tissue. Better symptoms. Maybe not remaining better, but could they position themselves there and help that tissue heal? Maybe you find a movement, maybe 2 or 3 reps. It's like, oh, I kind of like that. Oh, nope, if I do 5, it's horrible, right? So maybe 1 or 2 reps of something that seemed to be helpful. All right. So there's okay, well, let's do that. Maybe it's posture change alone. Maybe it's mid-range, like real gentle slouch over correct, mid-range, maybe lateral plane, gentle movement. I've sent people home with side glide to both sides, mid-range, gentle motion. I've sent people home with slouch over correct and mid-range, just the tiniest little movement, thinking that, what could this do? It seems so simple, but it could do a lot during this time. Or gentle rotation. So, just looking at just gentle mid-range movement, could that flush out some of this inflammatory cells and absorb nutrients and get some positive movement through the system? So you got to really look out for that, because you're not going to look for Texas big for those people. You're looking at very small, like, what are my options here? So position options, just lying prone, lying supine, lying in rotation. Is there certain postures and positions? I've had people with inflammatory dominant conditions just lay supine because it's the only place they can go that they felt kind of better. So every hour, 5 minutes, you're lying in this position to unload the tissue, take the stress off of it, right? If you think about the inflammatory stage, it does not take that long. Stage 1 is like 5 days or less. It doesn't take long if it has the perfect environment. So it's finding that perfect environment That's going to be the tough part, but it can be there. Then we've got posture correction, degrees of lumbar roll. We got reduce the amount of aggravating factors. So put all that together, and now most people are going to get through healing. All right. If they do their homework and you find all these different ways of helping it, most people are going to get better. Now, as we can also ask the doctor for medication to help us with the inflammation. And then we've got the transfemoral epidural steroid injection. So if you're struggling, and you'll know this in a couple weeks, I'm struggling to get this person to feel better. All right. Because if you have the right environment and it's capable of recovery, then you are going to see some minor changes, 5 to 10 days, 10 days to 2 weeks. Like, things are kind of getting better. It's not as intense. They might be moving a little bit better. Their reduction in symptoms, just that little bit of less symptoms, his intensity is going down. So then it just makes you keep working with them because you're seeing signs that you should. All right. Now, if it's just not, then we go back to, well, these are our options. We've got options of an injection, and this is the outcome in some of the research that we found. Or we could talk to the patient, and then we've got injection and surgery. How would you feel about an injection? How do you feel about that? This is what we find, the majority of people are going to improve with the injection. And then it really just comes down to what the patient wants. And I just offer it. I say, this is what we could do. Is that something you're interested in, or would you prefer to wait? And, to my surprise, a lot of people want to wait. There's a lot of people that they don't like the idea of that big shot going in their back.
In their back, yeah.
And a lot of people don't want surgery, So I just say, it is an option, and it could be a really helpful option, but it's really up to you, And if they want, sometimes they'll say, just ask me next week. Let's just give this one more week and see what happens, So it's just really, opening the options to the patient. I think that's really important. It's their body. They're feeling this, and we're just helping them along the way. So let's see. So if we're successful, and then, we can use those epidural steroid injections. But if successful, you will see in this phase gradual improvement in intensity, frequency, function, and movement. So it will be minor and it will not be huge. So you have to be okay with that, because we're so used to seeing those derangements get really big changes fairly fast. These are going to be minor, gradual changes, because it's going to take a good 8 weeks to 12 weeks to get these people through recovery. So we just don't expect anything huge. So it is noticeable. Then that takes us to as that patient goes through healing. So depending on where you're seeing them, they may already be in the subacute to chronic phase, or you may be taking them from acute into subacute and chronic. So it kind of depends where they're coming in. But let's look at subacute to chronic in repair phase 2 going into repair phase 3. So symptoms here now are typically more intermittent. They're less irritable. They're more tolerant to the movement. And movement loss is still present. You will see the obstruction to motion still there. Your tolerance is better. They can push into it. It might still pinch that nerve a bit, but it just sort of calms down fairly much easier. Not as much long-lasting worsening symptoms. So mechanical pain now is dominating the picture. So then now our goal is, well, can we start to restore movement and function? So think about the people who are not painful. They have full motion, normal movement, nothing hurts. These people have obstruction to movement typically. It's very painful and it pinches. So if you can get that joint to move normal, then nothing's going to pinch on it. So you kind of have to think about it that way. It's like, well, can I now get this joint moving better? And now we've got the MDT red light, yellow light, green light. How much can we push into this? Well, if we pay attention to the symptoms, we will know if we pay close attention. So our goal is to restore the motion. How are we going to do this? Is we're going to address the impairments that they have. So how do we do that? It's going to be through what type of range of motion. If we can work into the obstruction, then just very easy, like just bump into that obstruction, you may get an increase, but no worse effect. That's what we want, or produce not worse effect. Then the question is, if we can do that, not make them worse, then what's the right dosage? Well, that just depends on the tolerance. Maybe it's 5 reps 3 times a day. Maybe it's 3 reps 5 times a day. Maybe it's 10 reps 3 times a day. So it really just depends on what that nerve and what that tissue can handle, what the patient can handle, how quickly it calms down. So we'll learn that information in the clinic. And then the question is, well, should I go lateral first or sagittal first, right? Should I look at the lateral movements before the sagittal movements? If there's a large lateral obstruction, then I'm going to start working lateral first, trying to clear the lateral compartment, get that moving with better quality and less pinching of the nerve, and then gradually bringing in the sagittal plane movement that's obstructed. We talked about dosage. That depends on the patient. But then we also, if that doesn't work, it's like the more you push into it, the worse they feel, then that's not an option. So then you got to look at, well, what about opening up the space? I have used opening up the space with rotation and flexion. I have used flexion and step standing for some of these people, and I've looked at inflection. And what happens, you open up the space, you give it enough room, it calms down, and then finally I can now start working into the obstruction. So and then you do both. Maybe you go open up and then a little bit of closing down, or closing down and then a little bit of opening up. So you've got so many different options. It's just finding what the problem can handle. And then you look at maybe slouch over correct at mid-range, but working towards end range, like pushing into a little bit of that pain, but not too much. You could, and then decide like how much dosage. I've had some of these people just use slouch over correct and gradually get significantly better. And movement starts to restore itself. And what happens is, as these people get better, you just, as time goes by and you've got this environment of working through the impairments and trying to recover motion, symptoms get less intense. You can tell healing is taking place. Movement quality is getting better. Movement is starting to get more normal, not as pinchy, not as obstructed. And then you've got to also consider, as you're working through this and you're going about every 10 days to 2 weeks, the question is, are they starting to show signs of maybe becoming a derangement and actually having a directional preference? And all you have to do is take a few of those repeated movements and test it. And you will find those that are becoming derangements that now are starting to centralize. And then some won't, and some will. You just have to be attentive to testing and making sure that you're not missing anything. But all along the while, patients generally, you'll see changes probably about 10 days to 2 weeks, that the change is noticeable and a little more obvious. And then you start getting into function. Once they can tolerate weight bearing better, they're not as irritable, they can tolerate movement better, then it's time to start conditioning, and you start light and more neutral exercises. It might be upper body conditioning, even for a lower body problem. Just getting some activity. It may be walking. It may be then progressing to squats and heel raises and lunges, and more functional type of exercises. And some that are really not tolerating weight bearing yet, but you want to see if they can do a little bit of conditioning. Maybe you do some lying down conditioning and getting them a little bit more active. Maybe it's a leg lift. Maybe it's sideline hip abduction. Just something simple, something that really just kind of starts the process of being more active. In the later stages, you may have to start working on neural tension, neural glides, and stuff like that to get the nerve moving better and tolerating movement better. So that's, you'll move into those types of exercises. And our expectation is, if they're recovering, you will see an increase in motion and decrease in frequency, duration of symptoms, and improving function. And you will just keep going in that direction until they have full motion, full recovery. And so that's going to be the most common kind of how you're going to see these people go through healing and recovery and how you're going to do it. Then I've had some, we talked about centrally sensitized. So this is kind of an interesting group. I've had my share of these people. They have unique characteristics. It's typically towards, they're not in the inflammatory state, and they're well into like the third phase of healing where the nerve remains very hypersensitive. Their motion not necessarily is bad. Like their movement loss is much less significant. They might still have it, but you start putting a little bit of pressure on the nerve and it's like, oh, there's my leg symptom. They have good motion, but that little pressure is like picks up on it. It's very hypersensitive. Or they're just centrally sensitized and it's just hypersensitive and very well aware of everything because it's been there for a while. So for these people, you'll find yourself being in the more mid-range kind of movements and bumping into a little bit of that sensitivity, but not too much where it kind of lingers around. And you might find yourself not being able to use as many reps of an exercise. You might be using 3 to 5 reps of easier exercises than more challenging exercises that really stir it up. But slowly but surely you get you add more exposure. So like that graded exposure kind of process. And then those people start to get better too. So that's sort of that's sort of my experience, like, kind of what I like to do with these people. And I've seen most of them get better. Very few have I had to refer out, so I refer out for the injections, but it's oftentimes by the time they get their injection, they really don't need it because it takes so long to get to that picture, to get into the specialist. Mm-hmm. So, but sometimes they just go get it anyway. And sometimes they still need it and still benefit from it. So, but yeah, that's my experience with it. I see a ton of back pain and very few have to move on to surgery.
And like on the injection aspect, do you refer them out to injections more on the first stage that you mentioned, like acute, repair 1 and repair 2, or not necessarily? It could be in any stage if they're not progressing well.
It could be any stage that they're not progressing well. So signs of I'm the same, and their baselines are truly the same, and you try to change ways to move them and stuff like that, and it still doesn't work. So yeah, so when I'm noticing very, very much their response is the same, and then 3 visits in, I'm like, this is not changing, I will share them that option of getting an injection with them. It might be 3 or 4 visits, depending on kind of where we are and determining the problem and stuff like that, and let them decide. And most of them say, no, I want to wait a little bit longer. So I'm like, okay, let's work through this. And sometimes they then start to change or not, and then they finally decide to just go ahead and get that process started.
Mm-hmm. And when you're talking about opening space, I just have a question about that flexion with rotation. Do you usually do the painful side up, down? Does it matter? In your experience, what do you think?
Typically painful side up.
Okay.
So yeah. So I am typically working into those closing down directions, and it's not going well. It's really irritable to their nerve. So then I do the opposite and open up, and look what opening up could do for me or for them.
Okay. It's a little bit different from the rationale that we usually use with the painful side down. So you're just trying to let the nerve breathe there and give some space.
Yeah. And every once in a while, even derangements, could have that as a directional preference, being symptom side up. So I will typically look at symptom side down first. And then if that is not helpful, not a directional preference, then I'll do the opposite and see what happens. Every once in a while, you'll get some directional preference there.
Very interesting. Okay. Well, you gave a great overview. And like time, just to have an idea of timeline, do you feel like that first stage that they are more irritable with more constant symptoms, how long does that stage last?
If you're effective at giving it an environment for recovery, you will see constant symptoms go intermittent maybe in maybe 10 days to 2 weeks. Maybe the third visit. Yeah, maybe third to fourth. Like there's signs that it's starting to do that. So it won't be huge, but it will be signs.
Okay. And then the repair 3 that you mentioned?
How long is that?
The more intermittent phase before you go more towards function?
It's hard to say. Probably about, I don't know that I could put it all together for you. Maybe a month. I'm just going to throw it out there. Of working motion. It's really hard to say. As soon as
probably depends on the patient, on their presentation, right?
It does. How about this? If the sooner you can get them more active, the better.
Yeah.
And when can you do that is when they can tolerate it.
Yeah.
So let me give you some general considerations real quick with the MURs. So we should always be paying attention to our MDT principles of red, yellow, and green light. That lets us know on dosage. It lets us know what direction is appropriate, We should always do that. Always keeping track of the neuro status at each visit, baselines at each session, and when determining appropriateness of new treatment strategies. So you're introducing function, but is it appropriate? Well, are they having a red light, yellow light, or green light? Is it progressively worsening or not? So that will help us determine when they can start to, and always being attentive to the psychosocial needs of the patient, educating them frequently, asking them if they have any questions or concerns. When you open that up to patients, sometimes they'll just start to spew out all of their concerns, and they need to get it out, and then you can address them because then they're telling you what their concerns are, which is good. And then asking the patient if there's anything that you've missed, anything that you're not addressing that you feel needs to be addressed. You keep that open-ended because you need to be a team or else it's not going to work. And then always be attentive to their condition and if it warrants a referral during the process. So always being attentive to that. And your ultimate goal is to restore movement, strength, and function. And it's going to be slow, but steady, usually. So,
okay. And other than MDT, the MDT approach, do you have any other tips or something that you find that's helpful that you use with your patients?
I think that the MDT approach is really just your assessment. Your assessment process through the whole process of recovery, and then the interventions are your general physical therapy, right? Your range of motion, when do I use mobilizations versus self-generated forces? All of that is really just your MDT, but really physical therapy too. It's just restoring motion. When do you use neural glides? That's gonna be based on whether or not they still have tension that's not changing. Their range of motion is getting better, but tension is still there. Then we may need to start bringing in some neural glides. And then that function, are they an athlete that needs to get back to, an athletic or the athletic field, or are they a high functioning runner, biker, whatever, and getting them back into their normal daily life. So I would say MDT is really the foundation of helping me make decisions and of all the physical therapy options that we have. Does that answer your question?
Yeah. No, yes, okay. Absolutely.
Okay.
Great. So before we transition to the final questions, any other consideration, anything else that you want to mention?
I don't think so. I think we've gotten to everything.
Yeah, we cover a lot.
Yeah.
So resource of information, anything that you recommend people to go to find more information about the topic or in general?
The MDT textbooks obviously are a good resource. The manuals, I enjoy reading the textbooks. They're very well written, very good information about both research and interventions, and of course your classification. So, and then of course you've got your resource list on the MDT website or the McKenzie Institute's website, and then the current literature that's out there. Keeping up with the current literature is good, and then the APTA practice guidelines are a useful resource.
Awesome. And what would be the best advice that you can give to clinicians starting their careers?
Well, when I was a new grad, I started the track of MDT, and I do not regret it. It's the best decision I've ever made. So I don't know the other tracks, all right? So this is the best thing that ever happened to me. And I would recommend not just stopping at Part A or Part B. You know, that's just a little bit of a big world of MDT out there. And Diplomaed even has more to offer. So and then of course you've got your fellowships that you could do. I would highly recommend any of that. And then I think the level of expertise really will help you out in the clinic. You know, the more experience you get, the more you've gone through the training, the better you get. And I think the better you get at anything, just life is easier. You know, life is less stressful. So it's really nice to, be able to see a patient, just understand what their problem is and know what it needs, know what the outcome is going to be. Educating the patient easier. It's just a less stressful experience from 20 years ago, when I first started out. So I think getting experience and really becoming an expert at something, I think that this is helpful.
Yeah, absolutely.
And then just keep learning. And what I like about our careers is that the patient or you the clinician and the patient's connections. I've made so many connections, and good friendships that have come out of it, which is really, really nice, So anyway, I think that I really enjoy that part.
Yeah. And final question, personal qualities and abilities that you think are important to be a successful PT.
Okay, so this is what I'm thinking. I think if you like problem solving and if you like being a scientist, I think that's good. We're movement scientists. We're movement problem solvers, right? Like you're an investigator and you're a data collector. And if you enjoy that, you're going to enjoy this career. Collect the data, make sense of the data, problem solve it, and then
a good way to see things. Yeah.
It's like Sherlock Holmes, right? Like, why are you moving like that? And how do we fix it? But you have that aspect of it, but then you also have to be the motivator, the coach, the cheerleader, the encourager, you have all of that you have to go along with that scientist, part of it. And then enjoy developing relationships. And if you can enjoy the patient, I think you can really enjoy this career.
Yeah, I love the movement scientist. It makes a lot of sense.
Yeah,
it's a good way to look at it, a good way to describe. Kristi, if people want to learn more about you or if they want to find you, is there a way that they can connect with you?
Yeah, they can I've got 2 emails. I have Maguire Kristi, all one word. So MaguireKristi @gmail.com. And I have my work email, which is kristi.maguire@imcpt.com. And they can feel free to reach out to me if they have any questions.
Awesome. Kristi, thank you so much for taking the time to come share your expertise here with us and talk about this difficult topic. I feel like it's a challenge for us. The ones that centralize quick, it's nice and it's easy. And so talking about this group that's a little more complicated, I think is a challenge. So I appreciate you being willing to come here and talk to us about that.
It's my pleasure. Wherever I can help you out or help others out, that's good. Thank you, Mary.
Thank you so much.